Thank you, Dr. Eller. That was great. Next, we're going to move into our complex case discussion. We have three trainees who will be giving two different cases. We'll have Elizabeth Andrasky, who's a vascular surgery resident, and James Brown, who's a CT surgery resident, followed by Megan Gonzalez, who's a pediatric cardiology fellow. Thank you.
So thank you for the invitation to present today. We will be presenting a case of a 61-year-old female who had a history of multiple sclerosis, also had baseline right-sided weakness from that requiring a cane. She also had tobacco use. She had acute onset generalized weakness, left greater than right, which was new for her. She also had confusion and a little bit of chest pain, so she decided to go to the ED. There she was found to be hypotensive, required a little bit of supplementary oxygen. She had no abdominal complaints, and her peripheral vascular exam was unremarkable. On labs, she was found to have an elevated lactate and AKI. Her high sensitivity troponin was within normal limits. For that reason, she got a CT scan. As you can see, she ended up, she was found to have a DeBakey type 1 aortic dissection involving the innominate and the left carotid. As you can see, she also had a pericardial effusion concerning for a contained rupture. Her tear was complex. It appeared to involve the proximal arch at the base of the innominate. So for these reasons, it was decided to take her to the OR for an emergent repair. However, what should be the extent of her aortic arch repair? Should it be a limited or a complete repair? All with the goals of resecting the primary tear, and reestablishing true lumen flow in order to mitigate any branch vessel malperfusion. Given that planned repair, how are we going to protect the brain, and what will be the order of operation? How will we stabilize the aortic root if there's any pathology there? And should we intervene on the descending thoracic aorta in anticipation of any residual disease? Some general comments. The hemiarch replacement can be done in the majority of patients, roughly about 65% in our data. This involves a replacement of the lesser curvature of the aortic arch without the need for any arch vessel debranching. However, the remainder of patients require a more extensive operation, a total arch replacement. At our institution, this is done for 4 primary indications. Any tears involved in the aortic arch, circumferential dissection of the aortic arch, any concomitant arch aneurysm, and carotid artery dissection that is causing cerebral malperfusion that may or may not be associated with a static obstruction from a carotid artery thrombosis. Speaking of the root, most patients with aortic valve insufficiency at the time of their dissection do not have any underlying valve pathology, again, roughly 60-65% in our data. Rather, the aortic insufficiency comes from dissected tissue causing poor coaptation of the aortic valve leaflets. In this case, the aortic valve commissures can be resuspended with pledgeted sutures, and felt can be used to reconstruct the root media. That's depicted on the left panel. However, some patients require an aortic root replacement. This may or may not be a valve-sparing operation. Here, and uncontroversially, the aortic root replacement would be performed if there's any aortic root tear, a familial aortopathy, any concomitant root aneurysm, or any underlying valve pathology. So returning to our patient, because this patient had a proximal arch tear and also had clinical and radiographic signs of cerebral malperfusion, this patient underwent a total arch replacement. At this institution, we do an arch-first approach. We go straight to work on the arch while the patient is cooling. We sequentially debranch and anastomose the arch vessels to a custom trifurcate graft, which is depicted there on the left. This graft can be used as a conduit for an arterial cannula that serves as antegrade cerebral protection during circulatory arrest for the distal aortic anastomosis. However, our patient here got a zone 2 arch replacement, which is depicted on the right, as opposed to a zone 3 complete arch replacement. And this is why we wanted to present this case to describe the benefits of this approach. We did this for a couple reasons. For zone 2, it's technically less difficult than zone 3. Zone 2 is not as deep in the chest as zone 3, and it avoids the need to revascularize the left subclavian. Secondarily, we do this to reduce recurrent laryngeal nerve injury, which can be a major problem for these patients post-operatively. And finally, perhaps most importantly for this case, we keep open endovascular options for treating the distal arch and proximal descending for residual disease in those places, as will be seen in this case. Finally, there was no root tear or underlying valve pathology in this patient, so we did an aortic valve resuspension. The final operation is indicated there in the right panel.
So post-operatively, the patient did well. She ultimately made a full recovery, had some respiratory insufficiency requiring a trach, but was ultimately discharged, made a full recovery with no neurological deficits. This is her 3-month post-op follow-up scan. She did develop a residual type B dissection with aortic degeneration. Her initial scan measured the proximal descending aorta at 3.6 centimeters, and it now measured 4.5 centimeters, representing a 9 millimeter growth during that time period. She denied any symptoms of malperfusion or pain, but the decision was made to move forward with repair given this aortic expansion. So this case represents a case of rapid aortic expansion, which necessitates repair. However, I do want to touch on the current shifts in management of uncomplicated type B aortic dissection, de novo type B aortic dissection. There's growing literature to support TEVAR in the setting of high-risk anatomic features that portend increased risk of adverse aortic outcomes. These high-risk features include a primary entry tear at the greater curvature, short proximity of the entry tear to the left subclavian, an initial aortic diameter of 40 millimeters or more, and a false lumen diameter of greater than 22 millimeters, increased number or size of fenestrations, or finally an incomplete false lumen thrombosis. Now, notably, these are all drawn from retrospective studies that look at de novo type B aortic dissections, and they have yet to be tested in kind of the randomized trials. Now back to our patient, the decision was made to do a staged procedure, first revascularizing the left subclavian, followed by coverage with a TEVAR. While this was more controversial in the past, now there's a wealth of non-randomized literature to support the use of left subclavian revascularization prior or at the time of TEVAR coverage. In this case, they did a carotid or a subclavian transposition, but other surgical options include a carotid subclavian bypass and carotid axillary bypass. There are also endovascular options, including parallel stent grafts, scallops, fenestrated grafts, and also branched endografts at the time of TEVAR. So in our patient, after a staged transposition, the team performed a TEVAR. At the time of the TEVAR, first IVUS was used to confirm wire placement in the true lumen throughout its entirety, followed by deployment of the Terumo Relay Pro device at zone 1 under rapid pacing. Completion angio confirmed no endoleak, and the patient did well post-operatively. She is due for her first follow-up scan at the end of the month. So with that, I'd like to thank the course directors for the opportunity to present our today.
Good afternoon. I have another interesting case to present. First, I'd like to thank the organizers of this conference for giving me the opportunity to present this case. So first, for some background information on this patient, she is an 18-year-old pregnant female with Marfan syndrome with associated moderate aortic root dilation, as well as scoliosis status post to spinal fusion in 2017. She is followed closely by MFM and ACHD throughout her pregnancy and has had routinely scheduled echoes. Her most recent echo was done at 23 weeks gestation, which showed stable aortic root dilation of 3.8 centimeters. And she is currently on metoprolol, which was transitioned from losartan when she became pregnant. So the patient was seen in ACHD clinic for routine follow-up at 31 weeks gestation. Looking at her vitals, you can see that it was most notable for tachycardia, which really did persist throughout her visit. She also notes that she was recently diagnosed with a UTI at her local ER and is currently on antibiotics for this. And she notes that she has not been tolerating PO over the past few days, secondary to nausea and vomiting, which she attributes to her UTI. In addition to these complaints, she endorsed pretty concerning new neurologic symptoms that had progressed over the past several months. Specifically, she notes weakness and numbness of her extremities to the point that she's no longer able to stand and actually requires a wheelchair to ambulate. And she also has significant bowel and bladder incontinence that has worsened. She was actually seen by neurology a month prior to this visit. At this point, she underwent a spinal MRI that was unfortunately non-diagnostic due to her spinal hardware. She was then due to undergo a CT myelogram for further investigation. But during this procedure, prior to the start of it, she actually left AMA because she was concerned about the level of radiation during pregnancy. So back to her ACHD visit. As part of this visit, she underwent an echo, which showed increased aortic root dilation. In this echo, it measured 4 centimeters in comparison to 3.8 centimeters back at 23 weeks gestation. So in the setting of all these findings and concerns, she was directly admitted from clinic to McGee Women's Hospital for further investigation and workup. So upon admission, she underwent a CTA for more precise aortic measurements as well as a CT myelogram. Unfortunately, the CTA was a little bit limited just because it was a non-gated study and also had artifact from her spinal hardware. However, the results were concerning for a maximum aortic root measurement up to 4.4 centimeters, which represented a rapid increase in size, putting her at high risk for aortic dissection. The CT myelogram showed medial migration of 4 left pedicle screws as well as spinal cord compression, which is thought to be the source of her neurologic symptoms. It was therefore recommended that the screws be emergently removed, but her operative management was considered high risk just in the setting of her progressive aortic root dilation as well as her pregnancy. So after discussion with her many specialized teams, she ended up going to the OR, first for an emergent C-section at 32 weeks, followed by removal of her spinal hardware with ortho. And ortho found purulent fluid surrounding the screws and reported that the intra-op findings were consistent with a deep infection that likely led to loosening of the screws, and this loosening subsequently resulted in a medial shift of the screws and spinal cord compression. So in terms of her post-operative course, she actually did quite well. She did complete 6 weeks of antibiotics per ID's recommendation, although no pathogen was isolated. She did regain full function of her lower extremities following inpatient and outpatient spinal rehab. And she now has a healthy 18-month-old son with negative targeted FBN1 mutation testing. And reassuringly, her most recent cardiac MRI at 18 months postpartum shows stable aortic root dilation with a dimension of 3.8 centimeters, which is similar to at the beginning of her pregnancy. So I just wanted to highlight a few take-home points before wrapping up this case. First, pregnancy in Marfan syndrome is associated with a significant 8-fold increased risk of aortic dissection and is really most notable in the 3rd trimester and early postpartum time period, as we learned more about earlier this morning. Given this significant risk, close collaboration between cardiology and MFM is definitely recommended, and these patients need monthly to bi-monthly echoes during this time period for close monitoring. And finally, it's important to look outside the heart as well. This case displays a huge collaboration effort between multiple different subspecialties, and in this case, that was really critical to providing this patient with a good outcome. Thank you.